diseases. First of all, going back to history, we know that first models of experimentation have been undertaken in fetal lambs. I think one of the main reasons, reading a little bit, is because they are easier than other animal models to maintain catheter and fetal vasculature. Also, the fetal heart has 4 chambers. It does have a different placenta with 4 different vessels in the umbilical cord, but they do grow faster and have shorter pregnancies. Basically, in the 1930s, the British physiologist Joseph Barker published his first study with about fetal neonatal lambs, analyzing blood flow with 0 radiographies. And it's interesting to find those articles still online. They're available, and it's good literature review, actually. Later on in the 1950s, another British physiologist, Geoffrey Dawes, had more innovative information about hemodynamics of fetal circulations, also in fetal lambs. Later on in the late 70s, Dr. Abraham Rudolph, an American pediatric cardiologist, published the models of congenital heart diseases in fetal lambs, and he did contributed to the knowledge of cardiovascular and pulmonary physiology in the fetus. He has a wonderful published book for pediatric cardiologists, and it goes through in details all anomalies and pathologies and fetal circulation as well. So going through the matter, I thought this was a very colorful diagram to demonstrate the bloodstream in the fetus. So it's just a reminder initially how does the whole circulation follows through. So remember, gas exchange occurs in the placenta. Therefore, it needs to receive deoxygenated blood from fetal systemic organs and return its oxygen venous drainage to the fetal systemic arterial circulation. The fetal cardiovascular system is designed in such a way that oxygenated blood is delivered to myocardial membrane. And the circulatory adaptations are achieved in the fetus by preferential streaming of oxygenated blood in the presence of 3 main intracardiac and extracardiac shunts that we'll go through, such as the ductus venosus, the foramen ovale, and ductus arteriosus. So we have our placenta, which will receive deoxygenated blood via the umbilical arteries and return into the fetus via the umbilical vein. Between 50 to 60% of the placental venous flow bypasses the hepatic circulation via the ductus venosus, which is our first extracardiac shunt, to enter the inferior vena cava. Here we can see the different color flow. So inferior vena cava, less oxygenated flow, and then this is the preferential flow from the ductus venosus. In the IVC, like I said, the better oxygenated blood flow comes from the ductus venosus, and it tends to stream separately from the desaturated systemic venous blood, which is returning from lower body at around 20 to 40% of saturations. At the junction of the IVC and the right atrium, the eustachian valve tends to direct the more highly oxygenated blood towards the foramen ovale and then towards the left atrium. In the left atrium, there is better oxygenated blood entering the left ventricle and then being ejected to the aorta. The majority of the left ventricle blood is delivered to the brain and coronary circulation. Then the saturated blood from superior vena cava and the coronary sinus, in addition to the inferior vena cava, is directed across the right ventricle and then ejected to the PAs and then towards the lungs. Remember, because of the high pulmonary vascular resistance, only about 12% of the RV output enters the pulmonary circulation. The rest, 88, approximately, roughly, remaining crosses the ductus arteriosus and into the descending aorta, and then to the lower part of the body, which is supplied with relatively desaturated blood. There are many mechanisms, or a few mechanisms, that impacts on the high pulmonary vascular resistance. And remember that one of them is that the alveoli are full of amniotic fluid, causing constrictions of the arterioles, and therefore occurring the phenomenon of hypoxic pulmonary vasoconstriction. Um, so that is an overall of the fetal circulation there. Remember that all of these changes also occur due to multiple biochemical processes or changes that mature and develop along with gestational age. We know that circulating catecholamines, multiple hormones, and local release vasoactive substances all play an important role. We do know that due to catecholamines, there is an activation of alpha and beta adrenergic receptors, which do mature in early gestation, but the peripheral circulation of the fetus appears to be under a tonic adrenergic influence, predominantly vasoconstriction, mediated by catecholamines, particularly norepinephrine, and other factors as ABP, arginine vasopressin, and the renin-angiotensin system also have an important role. Remember as well that I said besides the pulmonary arterioles in pulmonary arterioles vasoconstricting in the pulmonary circulation impact on the pulmonary vascular resistance. Also, we do know that the ductal arteriosus contains muscle that is sensitive to oxygen tension and these vasoactive substances. And this is why the ductus arteriosus, along with low oxygen tension and vasodilation effect of prostaglandins, remains open. So this is basically the characteristics of a fetal circulation. Then, once the fetus begins to transition to a postnatal life, there are several adaptations that happens, and it's, this process occurs so rapidly, and so many changes that are, not visible to the eye. It's mind-blowing, I would say. And the fact that they were able to analyze this for nearly 100 years now, it's remarkable, and that we have so much information which aids to understand what happens in abnormal physiologies. So once this fetus is transitioning, even though it's quick, it does go through different phases. Remember that gas exchange now must be transferred from the placenta to the lungs. The fetal circulatory shunts will be closed, and the left ventricular output will increase. So there are a few phases. We call it immediate, intermediate, and late phases, basically. But once the cord is clamped, there is a significant drop of the pulmonary vascular resistance. The flow through the ductus venosus is false, and we do know that this flow closes passively between 3 to 10 days after birth. And also during late gestation, there will be a gradual reduction in PVR. Once the lungs are expanded, that's done. So once the lungs are expanded and pulmonary vascular resistance drops, there's an 8 to 10-fold increase in the pulmonary blood flow. Also, one of the reasons that pulmonary vascular resistance drops is mediated by stimulation of pulmonary stretch receptors, resulting in reflex vasodilatation, better oxygenation of neonatal blood, and also reversing pulmonary vasoconstriction caused by hypoxia. And that's in terms of pulmonary vascular resistance. Then in terms of systemic vascular resistance, the increase in pulmonary blood flow leads to a massive rise in pulmonary venous return towards the ALA. This decrease inferior vena cava flow and results in a fall in venous return to the right atrium. These two factors allow the pressures in left atrium and right atrium to equalize. At this point, the foramen ovale starts to close and the flap against the atrial septum until it's effectively closed. Sorry. Also remember that in the first stages, it is quite a vulnerable period because given a combination of circumstances, this normal process of a neonatal circulation could be easily reverted due to acidemia, hypoxemia, hypercarbia, and so on. And this is when we encounter reversal of our shunts and increase, when we have this status of pulmonary hypertension of the newborn. There are also an adaptation in terms of the cardiac output, and we know the changes that occurred with the ductus arteriosus. The left ventricle increases in preload and afterload. There is a better oxygen supply. The natal cardiac output is approximately 200 mils per kilo per minute. We do know that the myocardium cells are still, and the myocardial muscle still, there's a degree of stiffness, and feeling will be limited. Therefore, it's more dependent on the heart rate. And this is one of the explanations why neonates have a higher heart rate as well. Remember that the ductus arteriosus will establish a shunt reversal bidirectionally and finally left to right. It does have two phases before it closes completely. The first phase, it's due to increased oxygen content and restriction of prostaglandins, and then a functional closure by 60 to 96 hours, and that happens in most term babies as well. The final adaptation phase involves remodeling of pulmonary blood vessel musculature. The first few days, the wall thickness does improve, and finally, like I said, the ductus does closes due to endothelial destruction and subintimal proliferation. So finally, a successful transition will occur when there is blood flow to the pulmonary circulation, placenta is removed, and all pertinent shunts are closed. And that is overall neonatal circulation. Any questions?
No questions, but a comment. Thank you. That was very nice, very nicely depicted, very colorful, and very clear. So thanks for the lovely presentation today. We're open to questions.
Deborah, so with this adaptation process, so that means that it makes sense to wait for a few days before embarking any operation, putting on bypass or doing anything with a baby, if it's going to take a few days to adapt the myocyte and the pulmonary vascular resistance and so on. You think?
Yes, definitely. And I think and this is one of the main reasons why we go to parents, and especially when we do antenatal counseling. I think it is it's a vital thing to try to correlate a little bit of what it means to have a what is a normal fetal circulation and what happens with a baby with a congenital heart disease, because parents will expect things to happen in a in an immediate manner, and these are the reasons why we do need to wait, and why the baby will have a better outcome once a more then again, we do so many things to these babies when they're born. For example, ventilating the babies when they don't need to. That also delays things. Starting prostaglandins. Well, depends on the situations. Or there are things that need in order for all these.
Yeah. Because in some
Does that make sense?
yeah, it's because in some I remember, I think that, I don't know if Oleg is on the call or not, but
Because remember,
in
it's not only economical.
can you hear me now? Yeah. No, I don't know if Oleg is on the call, but in
Yes,
Ukraine,
hear you.
he was telling me that they do the transposition, the switches as soon as so the baby is born, and straight from being born, they take it to theater to do the operation, which anatomically probably is not terribly different from 2 weeks, 10 days later, but physiologically, I don't know if that's slightly aggressive, especially when you
I
need to
haven't
adapt
looked
for
into
a few days.
Yeah, I mean, I remember a few, well, in the past decade, 10 years ago, I mean, even in France, they used to do TGAs within a month time, actually. So yeah, I think you know, this is 21st century. We have many ways to maintain adequate hemodynamic states. So whether or not that's a bit aggressive, yeah, that one could see it from that point of view. Depends on the outcome they have as well.
Yeah, yeah, that's right. That's true.
Yeah, in Vietnam, they take them to theatre pretty much within the first couple of days of life as well. And then, but then interestingly, there's a large publication, well, last cohorts, multi-center cohort study of the timing of arterial switch procedure, starting out from Emil Basha when he works at New York. And they show that day 3 is the best time for the operation. But although the system is completely skewed with the because it factor in like a neurological outcome and as well as cost to the system. They did a regression analysis and they show that day 3 is the best day to go forward. And then that study has been updated recently with exactly the same cohorts, but then more long-term follow-up, and the result were quite similar. So it'll be interesting to look at that question as well at some stage.
Yeah.
I mean, he's well, not historically, probably the UK in general, because probably all the UK switch, program, if you want to call it, probably started with when the people who trained in Melbourne, Bill Brown and all that group, and Martin Leval that came over, and then they started to do the switch operation probably in the early 90s, I guess. So it's more or less the same process. And I think that the tendency in the UK historically is 7 to 10 days for a transposition normal. And because it's a different health system, isn't it? You're right. So in an American health system, having 7 days a baby in a hospital, it costs money before an operation.
Definitely.
Oh, sorry, Ramaraya wanted to ask a question.
No, thank you, Deborah, for your nice and short presentation. So, Raf, I got a surgical question. Like, I think in TGA circulation antenatally, we say both right and left heart are equally trained. The SVR is in fact a bit lesser, but it is balanced by the placental circulation. Then the SVR drops. In terms of the tissue fragility, do you I mean, does it does it make difference in terms of doing operation within 48 hours to 1 week or second week? What we perform here?
I think that the tissues, I don't think that within a week will make a huge difference.
Okay.
When we do TAPVDs in the first 24 hours, or sometimes we have to do switches very quickly, or the Norwoods and all that stuff. The tissues are probably about the same. But it really make a difference when you go beyond that. So if you are at 3 or 4 weeks, if you do a late switch for whatever reason, the tissues are definitely, I mean, my experience, they don't feel as fragile at all as a week-old baby. And that's only within 2 or 3 weeks difference. And so it's slightly, I don't think that is, maybe the heart will be a tiny bit bigger, but the tissues are more stronger. But not within 2 days or 5 days.
Okay. Yeah. So Deborah, coming back to a presentation, thank you for, it's nice and crisp. You mentioned all the salient points. So in terms of the variability of the fetal circulation, have you looked in, conditions like absent ductus venosus or conditions like your premature ductal stenosis, and how it can impact on fetal circulation from the normal to
Um,
like,
I must say I didn't look much into literature, but I guess it's a significant, important aspect, isn't it? Because
yeah,
we do know that this arteriosus so provides circulation to, rest of so lower parts of the body. We do know that the foraminal valley, as we say, basically develops the left ventricle, and it's able to send the blood to brain and coronaries. So I mean, I guess if we have a very small duct, even antenatally, um, the chances postnatally of inadequate oxygenation, I guess it's quite lower, anyways. And how could this impact on a congenital heart disease? It would be significant, I guess.
yeah. I think it'll be interesting to look into the. I mean, they're all kind of not that common cases, but we do come across now and then. The two different elements, you have nicely, your last slide shows the three fetal mixture from the placental circulation to the baby systemic circulation, or starting from ductus venosus, then foramen ovale and ductus arteriosus. So there can be variability in any of these three places, and
Yeah.
how it can potentially impact on fetal circulation. So, for example, if you say ductus venosus for any reason, can this be absent in a fetal circulation? Um, so if it goes absent, we do see, I think, very very rare, but I mean this year we had two cases. So where the umbilical vein directly, it can drain through the IVC, or it can drain directly into the right atrium. Then you can anticipate the associated problems around this area. So there is a buffer system in the ductus venosus going into the hepatic circulation and coming back into the right atrium. So on these particular babies, this buffer system is lost. So then you're looking into right heart distension in these babies, and the potential right heart failure, depending on how much, because there is no pressure buffer. So often you can expect, like if these babies, they present with a later gestation with a preserved RV function, then as soon as the baby delivers, there is no more need for ductus venosus, then they come back to normal. But if they get into problem, it can go up to the extreme of right heart failure, up to high drops and peritoneal and fluid collection on the right side. And also, in theory, the reported cases, because you don't go through the hepatic channel, you don't mature the hepatic and portal circulation antenatally, so they can present with the biliary and the hepatic problems. So it's just a variation of the ductus venosus, like how it can affect in a fetal circulation. Sorry, I think it's noisy with somebody's. Uh, Second, circulation point, mixing point is your foramen ovale. So if you have a small foramen ovale, say, or a pinhole foramen ovale, or a variation, or you can have a huge, common atrium, how it can affect your right heart to left heart mixing. So usually your ductus arteriosus, helps here, as long as you have a decent ductal arch in the fetal life. Your foramen ovale doesn't matter. In the it can offload, the right heart can offload through the ductal system to the systemic, and as soon as the baby is born, then ductal system is going to go. Then the pulmonary arteries, they're going to take over. So, but if you have associated congenital conditions where or any other conditions that can affect the size of your ductus arteriosus, or say, for example, premature ductal arterious stenosis or closure, which can be spontaneous or which can be drug induced, like a non-steroidal or any other maternal drug use, then that can potentially affect your right heart offloading. So in that situation, if you have a bigger foramen ovale, then right heart can offload through the left heart, and those children, those fetus, potentially, like they suffer less right-sided
Yeah.
damage and less right-sided, pressure impact onto the lung. Say, for example, you got a condition where you have a pinhole foramen ovale, and unfortunately that duct is also closing in a very early gestation. Then you don't have any right heart offloading possibility. Then that can impact on very high pressure RV hypertrophy and RV failure and high drops kind of presentation. And also you can expect that lung can have abnormal pulmonary vasculature, so which can give rise to even irreversible persistent pulmonary hypertension of newborn, and they can succumb into death after birth. So it depends on the balance, but fortunately majority of the cases what we have come through under the literature, and there is one circulation paper on this as well, in a European, they studied like a 15 cases up to on premature ductal stenosis and closure. Majority of them, they survive because they have a decent foramen ovale, and after birth, your ductus role is very minimal. So as long as the lung pressure drops in the right way. So these are all just variations. So if you put into the context of physiology, then it kind of makes you to analyze and think the fetal circulation and how it can impact during the fetal life and the transition, and what you can expect and alert the neonatology input in this situation.
So Ram, do you think that the couple of questions?
Yes.
If you have a big foramen ovale or
Yeah.
good interrectal communication, can that ameliorate the PPHN? So can that help for the physiology of that? And if the answer is yes, is septostomy a role? The septostomy will have a role in that. And the other thing is any impact of the fetal circulation adaptation on prematurity? So what's the relationship between that? So because we have so many prematures, do we need to think about
that? I think the neonatal experience is, roughly prematurity doesn't impact much on the, there are associated more high risk factors like IUGR, chromosomes, and syndromic that can affect the microvasculature in the pulmonary bed. But lots of premature babies we see, and even like if you scan them, by the end of a few days, you could see a completely left to right duct within few days. So that shows as soon as the aeration start happening and the physiological stimuli start happening to the pulmonary vasculature, their pressure drop, and then they are only facing the bad chronic or RDS type of lung element of it, and the premature alveoli element, and the pulmonary vascular bed. It works similar to term baby, but there is slightly, this is my experience, there is elevated risk when you have a preterm with IUGR and with a stressed lung, or if you have any other associated lung malformation, then you can anticipate persistent high lung pressure maintained in the microvasculature. Then if that baby suffers with a additional bad chronic lung disease RDS picture, I shouldn't say chronic lung disease, in early stage RDS picture, then those are the bad sufferers, I think. Maybe in that situation, a duct, can help in terms of offloading, and which is physiologically maintained in some babies. We do see, like this bidirectional ducts. It takes a month, then gradually as the lung matures, if the pulmonary pressure drops, then it goes to left to right. But if it doesn't, then those babies are the ones who are stuck with the persistent pulmonary hypertension. So now I think we have other cardiologists here. Fu Leng, you can input on preterm duct and bidirectional shunts.
I mean, there's a lot of studies going on at the minute, really, isn't it? And the latest one is to see whether they can give maternal oxygen to see whether it changes the outcome of some of these conditions. And unfortunately, so far the result hasn't been very encouraging as yet. And people look into like doing MRI and look at the flows and try to grow certain chambers because basically to force flow through. For example, like plastic like parts, they try to give maternal oxygen and would be able to increase oxygen and drop the PVR of the child with affected chamber. So then it's just force more flow through and then therefore growing the chamber. But so far, so I think that's been going on for like the last couple of years at least. And that has just this year's at the American Society of Echocardiography meeting, they haven't shown much improvement as yet. But hopefully there will be, obviously the conclusion is that there are multiple factors as you highlighted, is chromosomes, is nutrition and various other things potentially. So oxygen itself isn't just the only thing, but yeah. So it's a very interesting field, and we yet still not sure as to how much is enough and how much is too little for this circulation.
So I'll try to answer the question about whether fetal atrial septal intervention makes any difference. So the last set I reviewed the literature on fetal cardiac interventions, atrial septal interventions with whether atrial septostomy or atrial stenting is still very, very rarely done worldwide. So Boston group has the widest experience. They've only done 21. And there's also this International Fetal Cardiac Intervention Registry, and they've got 37 in them. So technically, I think success is quite high. So they reported 90%, so 65 to 90% in these two cohorts, and both had similar survival to discharge. However, when they compared this group with restrictive or even intact atrial septum with a group that had intervention fetally and a group that didn't have intervention, they didn't show any change in survival overall in terms of discharge to hospital and 1-year mortality. So it's very difficult to tell in this case whether fetal atrial intervention has made an impact or not, and it really depends on the gestation that you're doing the intervention on, because the earlier you do, the higher risk of fetal demise anyway. So within these two cohorts that they've attended fetal atrial interventions, there's a fetal demise rate of 10 to 14%.
Yeah, amongst the normal or normal preterm babies, to answer the second question, what you asked, the size of the atrial septum, I don't think it impacts on the overall risk of the pulmonary hypertension in preterm or newborns, because we have come across, even with the very big common atrium babies, if they have other associated risk, for example, preterm Down syndrome babies, they have kind of lingered in a neonatal unit for 2 months, up to 2 months with a high pulmonary vascular resistance and needed nitric sildenafil. Then gradually they were able to wean, and some they're stuck with the very high pulmonary vascular resistance, and they needed to go. Either they succumbed to that or they needed to go long-term therapy with a pulmonary vasculature, GOS team for a lifelong pulmonary arterial disease. So I think the septal intervention will help if it's a pulmonary venous congestion induced. That's what we are used to as a cardiologist, pulmonary venous congestion induced pulmonary pressure rise. But if the baby has got innate pulmonary arterial disease, or if they have high risk factors for that, that's how they are born. I think it looks like that's the nature of the baby.
So in summary, the baby with PPHN, which is potentially going to ECMO because it's not saturating, and you have doing a septostomy will not make any difference to the physiology.
Yeah, I mean,
not by that stage, I think.
Not at that stage.
I don't think. No,
that's fine.
Because, yeah,
I was trying to find some jobs for the intervention chaps. That's all.
No, I think that's the experience with I worked in Leicester, the PICU for they do get quite a lot of respiratory ECMOs, and I mean, when in a good candidate, the recovery is within 5 days, which is very good, and that's all dependent on independent pulmonary vasculature that reverses when you give rest, and not dependent on the anatomical side of the heart.
Okay.
I mean, it's not entirely futile, Rafael. I think it's patient selection, and in larger centers, they go through several iterations of redefining patient selection. At what stage, what gestation and what weight, it all obviously counts into the final outcome.
Okay. Interesting. I never thought I was going to be a bit interested in the fetal circulation, but here we are.
It wasn't a long presentation because I think we've all done this many times, either in medical school and during our training. It's just a reminder, I guess. So thank you.
Yeah, sure, Deborah. Thank you. Anybody else got any comments? So we have a few more fetal topics. I think in next 2 or 3 weeks, we will try and cover more anatomical part of fetal lesions and rhythm, and as well as palliative fetal physiology.
Are they going to talk about fetal intervention or no?
It's Leng already
Yes,
given
I
us.
can. I can. I mean, yes, I can.
Yeah, we can incorporate into the 4-chamber and outflow tract lesions with the Leng's research.
There's not many fetal interventions, to be fair. There's the most common is fetal aortic valvuloplasty, and then pulmonary valvuloplasty caught on because of aortic valvuloplasty, and then there's atrial septal interventions either for hyperplasty with intact septum or for transposition. That's really about it. So if I talked on it, it'd be also 15 minutes.
What about fetal surgery? Not yet.
Fetal surgery is actually very interesting. So I've been hearing from Prof. Losty about what's being done. So if you guys are interested, out of the heart as well, then I could read a bit about that. Ask him, and we could do that as well in this forum. But
many years ago, I was so interested because there was a lot of talk about trying to do the operation because you don't have a healing. Sorry, there is no scar tissue when you are in as a fetus. Sorry.
Yeah.
So if you have, like, for example, a coarctation, which is impossible, isn't it? But like a hypoplastic arch, then you can repair that and you will not have a scar tissue. So that would be good for a redo. But yeah, it's probably not viable at the moment. Great. Thank you, guys.
Thank you all. Thank you.
Thank you, everyone.
Very good talk.
Thank you.
Well done, Deborah. Thanks. Bye.
Thank you.
Thank
Cheers.
you. Very nice.